Welcome back to the UB Medicine Podcast. I'm Dr. Allison Brashear, the Dean of the Jacobs School of Medicine and Biomedical Sciences and the Vice President for Health Sciences at the University at Buffalo. In today's episode, we're exploring breakthroughs in neurology, from stroke to migraine, and really how our faculty are driving innovation and research in patient care. I'm joined by two outstanding colleagues. Dr. Daniel Wu is the Irving and Rosemary Smith Endowed Chair of Neurology at the Jacobs School. He's a pioneer in the genetics epidemiology of stroke, and Dr. Wu is one of the most consistently funded investigators in neurology nationwide. He joined us here at UB, and he's now taken on the Associate Director of the Clinical and Translational Science Institute, where he's helping to accelerate discoveries in stroke, imaging, prevention, and recovery, therefore bringing research from bench to bedside and, importantly, training the next generation of physician scientists. Dr. Melissa Rahill is the Clinical Associate Professor of Neurology and Division Chief of Headache Medicine and Adult Neurology Program Director here at the Jacobs School. And most recently, she was named the Vice Chair of Education for the Department of Neurology. She is a nationally recognized expert in headache medicine whose research has focused on improving the patient experience through clinical trials, personalized care, and advocacy. And her work is really focused on understanding migraine as really a complex disease and how we then educate and shape the future of neurology. So I'm going to start first. We're going to really focus on the brain. And first, Dr. Wu, first of all, thank you for being here. Thank you for coming to the Jacobs School. We really are so glad that you joined us. Before we start talking about stroke, can you just tell me, what is a neurologist? And full transparency, I'm a neurologist, so I know the answer, but for our audience, what is a neurologist?
Sure. A neurologist studies diseases and the condition of the brain, spinal cord, nerves, and muscles. It affects people in one of the most personal ways: your ability to speak, your ability to think, your ability to concentrate, your ability to move your arms and legs, your ability to function in the day-to-day world. And I also am a strong believer that neurologists shouldn't just be studying the diseases of the brain, but how to keep the brain healthy, how to keep neurological function going as well. And we made a lot of discoveries in the last 25 years of how your brain works. I have a lecture I like to give about an operating manual for your brain. How do we create new pathways? How do we learn things? How do we develop cognitive reserve as well? We are distinct from neurosurgery, but we assist neurosurgeons all the time. So we don't do surgery ourselves, but we're doing everything from epilepsy surgery. We can actually cure somebody by removing their epileptic focus. Deep brain stimulators for certain neurological conditions like Parkinson's disease. And we also do a lot of stroke work with the help of our interventional colleagues. We can go all the way up to the clot inside the brain and actually extract it or open up the blood vessel within the brain.
That's great. So brain health is probably a topic for another whole podcast on how we keep our brains healthy. There's been a lot of advances in stroke, Dan, and can you just give us a little bit of eyes into that? When I trained, it was aspirin. Do you take one or do you take four? And now there's so much. Some of that has to do with imaging and other devices.
Perhaps the greatest achievement in stroke care has been the advent of removing the blood clot before that part of the brain dies. But it had to have very careful patient selection because a lot of the brain could already have died from the initiation of the stroke. So there's a technology that uses the CAT scans, imaging, and perfusion to determine what part of that brain hasn't died yet. If a large part, we should go and rescue that. If the entire part of the brain has already passed away, we shouldn't have those procedures done in that part. So this technology has really improved our care and selection of patients that we can make a huge impact on. And it's been dramatic, the changes. Used to have a lot of patients would have massive strokes on one side of their brain. It would even swell and cause herniation. There's this procedure called a hemicraniectomy where we try and manage that swelling. But many of us can't remember the last time we've seen one of these procedures done because we're doing so much better job of preventing that massive stroke from occurring.
And the neurologists are really part of making those decisions and then also preventing stroke, so secondary prevention. Can you say a little bit about secondary prevention? So someone comes and has a stroke and then they go back home and they recover. And how do you, as a neurologist, counsel the patient so they don't have another one, which I'm sure they're very scared of?
Definitely right after the stroke is when they're at their highest risk of having a recurrent stroke. Even up to a year to 5 years out, there's still an elevated risk. Yet, modern medication and other exercise and dietary regimens have dramatically reduced the risk of stroke. Matter of fact, certain regimens have beaten out using a catheter device to open up blockages inside the brain because they're so effective at reducing your risk of having a future stroke. And so definitely one of my big things has to do with taking this moment when somebody's just had a stroke to say, you're at very high risk in the next 5 years of developing death or another major stroke. This is a good time to get religion about your health. It's a good time to address your risk factors. A little bit of exercise. I don't need you to become an Olympian, but a little bit of exercise where you get huffing and puffing and breaking out sweat can make a huge difference to your cardiovascular risk factor profile. Then there's also lots of additional risk factors that we didn't even know about that existed before that we're now discovering. Everything from sleep apnea, headache, health, mental health, and how we can address those risk factors in order to improve brain health.
Well, a little bit about genetics, because you've had huge studies in genetics and genetics risk factors for hemorrhagic stroke in particular. So how do your genes play into, because the genes you can't really alter?
Yes, you can't change the genes, but you can find out what the genes do and address those risk factors. And what we're discovering is, unlike many of the diseases we learned in medical school, like sickle cell, where one mutation caused the disease, we're discovering that really there are hundreds of different variants throughout your body. And it's kind of the accumulation of those. Then there's epigenetics, things that happen to you decades ago in your life, periods of food insecurity, housing insecurity, stress, anxiety. All these things can build up to turn on certain genes that you don't really want or turn off genes that you do want. And so this combination of things then adds up to your total risk. If we can understand what the pathway is that those variants are causing, we can now address those. My particular risk factor that I've identified, which we're hopefully is going to be a novel risk factor, relates to something that's both dietary and genetic. And if true, there are already medications that can lower it. So even if we can't change people's genes, we can identify novel risk factors through it and address those.
That's terrific. So you mentioned something about, genetics and maybe medication. Since you've come to UB, you've joined Dr. Sanjay Sethi that now it's leading the Clinical Translational Science Institute, and you're the Associate Program Director. And can you tell us a little bit about the importance of bench to bedside and also the importance about clinical trials and people participating in clinical trials?
Absolutely. So for those who don't know, on the bench side, whether it's animal models or in a petri dish, you can have a lot of control in the experiment, so you can fundamentally test whether what you think is happening is actually happening through those kinds of experiments. We can't experiment on human beings that way. And so that is a critical part for our getting basic understanding. And once we have enough evidence, then we take it to the clinical bedside. All the advances that we have today, we are really grateful to all the people who participate in those research studies. If people don't participate in those research studies, then we can never make the advancements that everybody enjoys today. And so it's critically important that people understand that you're not a guinea pig, you're not a lab rat or anything like that to us as researchers. We definitely don't want to do anything that harms our patients, but we do need to have scientific research in order to prove that something really does work so that everybody can benefit from that. So we really do need participation of people into those research studies.
And the clinical trials are compared usually against usual care. And oftentimes people involved in clinical trials see the doctor more frequently. They get more frequent testing. They oftentimes, or almost always, the treatments are provided free of charge. And so there's a great deal of benefit to participating in clinical trials, as well as giving back, as you mentioned, when something's been life-saving. For example, you've had a stroke and then you are in a secondary prevention study or a study that is designed to figure out how to prevent a second stroke.
Absolutely. So the worst that a patient can get is the best care that we can provide. That would be the standard medical treatment arm. The experimental arm usually has something that has been tested for safety, and we're looking to see if it's more efficacious than the standard of care. And so, and again, as you say, most people that are in that could have access to treatments that could cost so much that they can't possibly get it, or insurance won't cover it because it hasn't been proven yet. But in addition to your own personal benefit, generations after you will benefit from that. Your kids, your grandkids, society, and so forth will benefit your participation. Even if the study is negative, that is an important scientific advancement for us to understand, and it helps to advance care throughout.
And lastly, stroke care is a team effort, right? There's the people that do rehab, the rehab docs, the PT, OT, speech therapists. You mentioned the involvement with neurosurgery in the acute phase. There's the primary, secondary prevention. You work closely with cardiologists, and I'm sure I'm forgetting any number of specialists and providers. Can you just emphasize or clarify just how important that is, right? Nobody does this alone. Particularly stroke care is a team sport.
Definitely. I think in all of medicine, we're becoming much more multidisciplinary. It used to be there was one doctor, say a stroke doctor, and manage everything about it. But really, even recovery and rehab for neurological disease has its own subspecialty. We're learning so much about reparative mechanisms throughout the human body. How does your brain actually recover from diseases? Why do some people recover, some people don't? A lot of it has to do with inflammation. And then again, the multidisciplinary subspecialties, that brings in a team of different people, whether it's a neurosurgeon, a cardiologist, a risk factor management for primary care, all the way through neurology and through rehabilitation.
So we talked a lot about acute stroke. Now we're going to pivot, and we've got Dr. Rahill sitting here with you, and you take care of patients with migraine. What is a migraine? And my memory is that it is quite disabling. It keeps people out of work.
It absolutely does. It's one of the leading causes of years lived with disability worldwide, especially for women under 50. It's the number one cause. But I love how you asked the question, what is a migraine? Because I would argue that migraine is not a series of individual migraines, but actually it's a neurological condition with a genetic basis. It's a neurobiological condition. And so a lot of people may feel susceptible to different triggers for their headache, and there's a variety of factors that can influence that. I'm sure you guys both have had the experience where you haven't slept well once in a while.
Oh, Deans sleep really well all the time, for sure.
Or stress. You guys are never stressed, I'm sure, in your roles. But those things actually have a neurobiological impact on the migraine machinery in the brain. So it's not just that migraine is a hysterical woman's problem. Like a lot of times, our patients have a lot of societal stigma with migraine, and men get migraine too. But there is a neurobiological basis for this problem. And you're right, it is incredibly disabling. So I feel there's no better feeling than finding a treatment that works for somebody where they can actually get back to work. They can get back to their family. They can just feel a little bit more predictability in their life when they know that their treatment is going to have their back. So I think, especially nowadays, it's just been a really exciting time to be a headache doc.
Yeah, it's an exciting time to be in neurology. So from stroke treatments to migraine treatments, there's any number of infusions, injections, pills that didn't exist even 5-10 years ago. So how does somebody sort through all of that? Some are very expensive, some are generic and exceptionally inexpensive. What's the best way to deal with that?
Yeah, that is, I think, the question of the decade in headache medicine. And there's a lot of really interesting controversy now within the field because we have these conventional, tried and true oral medications that were not specifically developed for migraine, but do have, they're effective for migraine prevention. And now, as you mentioned, we have this laundry list, thankfully, of new treatments that are incredibly expensive. Although I think on the whole, most headache specialists would agree that the new treatments tend to be a lot more better tolerated than our conventional therapies. And so you have to ask yourself, if the older conventional therapies, 30% of people are still on those at the end of 1 year, think about the opportunity cost there. And so some people would argue that going with some of these newer therapies might have additional benefits in spite of their risk. In spite of their cost, I should say. But then others feel like, some people do great with the oral conventional therapies and think about the cost savings to society. So it is a hot area of debate within headache medicine.
And when people have headaches, how do they decide, we're putting in the new EHR across our community, Epic, with our hospital partners, but people go to the emergency room a lot. And we have a lot of people listening to this podcast, whether they're patients, students, future neurologists, maybe a few. What guidance do you give people? Because migraines are scary, but there's your typical migraine and your atypical migraine.
Yes. So I think that's why I love being a clinician educator so much, because there are only several hundred headache specialists in our country, and there's around 40 million people with migraine just in the US alone, 1 billion with a B worldwide.
How many people in the US have migraines?
About 40 million.
Oh my, we're going to need to clone you. Goodness gracious.
I'll let the geneticist figure that one out.
Okay, so how does that fit into your role as educator?
Right.
Because you're teaching medical students. All of our medical students now go through neurology. Everybody meets you.
It's one of my favorite days of the year to give my headache lecture to our second year students in our neuroscience course, because I know that in doing so, they will be empowered to care for patients with headache out in our community. I really feel strong about education of patients and the public about headache awareness and migraine awareness, because we don't want people to end up in the emergency room. We want people to be well and to prevent, loss of work and loss of time from family. So I think education really plays a huge role in that.
And educating both the future doctors, but also the patients on what they can do. So,
yes.
One of the things is go to sleep at the same time all the time, or don't eat hot dogs or chocolate or whatever, right? There's a lot of different things.
Yes, I think there's a lot of talk about trigger avoidance. However, I would argue that some people will naturally have ups and downs throughout their life. And if you institute good treatment, then you tend to not be quite as sensitive to your typical triggers. So I would encourage people that if you're suffering a lot from headache and migraine, reach out to your primary care doctor first. Reach out to a general neurologist or a headache specialist, because you don't necessarily have to suffer quite that way. I think behavioral modification, lifestyle changes can be helpful. Often they are insufficient for people with more frequent headache. But things like getting a good night's sleep, that means you too as well, not skipping meals, good hydration, avoidance of alcohol, those are important. But if you're suffering in spite of doing your best with that, then definitely reach out.
As somebody who likes hot dogs and chocolate, I agree with you wholeheartedly.
Oh, I never take away chocolate from people. Absolutely not.
Well, you both have been committed to really patient-centered care, and in your work, both treating patients in the clinic and your clinical trials. What is something that you think, we talked a little bit about the importance of clinical trials in stroke, but in headache, that's a big piece of bringing these true treatments. So can you give us a little bit more insights?
Yeah, so right now, as I said, there's this big debate over how to incorporate the newer treatments into clinical practice compared to the conventional treatments. So they're just starting to undergo clinical trials about comparing our conventional therapies to our newer therapies. I think there's going to be a lot of work done in terms of cost analysis. I think, we're oftentimes now focusing in on the most bothersome symptom and not just headache days per month in clinical trials, which I think is really important. And it highlights the effect of including patients in on the research process, like focusing in on that most bothersome symptom. For some people, it's not the pain of the headache, it's the nausea. Once you're nauseated and, the game's over, right? You can't stay at work anymore. So I think that's been a really important piece too.
I think it's also important to point out that these are good problems to have, that you don't know which one to do.
Oh,
because there was a time when we only had the one medication, and I think about the advancements that are occurring in, Alzheimer's disease and the infusion therapies that are going on there. In Parkinson's disease, the newer medications they have versus deep brain stimulator and surgeries that they're doing on that side of things. I just think that neurology has grown so much in my career. And I was just saying to the next neurology resident interview class, what an exciting time to be part of neurology, the things that are going to happen during their careers. Real cures for things like Alzheimer's and vascular dementia, true brain recovery from injury, spinal cord injuries, neuropathies. These are all things that it has taken a whole generation of science and advancement to understand the molecular basis of these things. And think of what it's done for migraines, understanding the molecular basis of that and finding real treatments for it. A good problem to have. Well, which one should we do?
Yes.
So we're going to close, and I'm going to ask you for one or two sentences to sum up what you think about the future of transforming health in Western New York in neurology. So I'll start with you, Dr. Rahil.
Yeah, so as a residency program director and vice chair for education, I think one thing that I'm super excited about our future is training our future neurologists, because we have a shortage of neurologists in our Western New York community. And so I think to have the biggest impact, we are growing our educational programs in our department right now. And I can't wait to focus on retaining those folks and better serving our community and improving access to neurology.
That's wonderful. And Dr. Wu, I'll ask you the same question. How is neurology going to transform the health of Western New York?
So neurologic disease is the fastest growing subspecialty disease in the United States. And because of that, we have an unusual shortage, as Dr. Rahil said. And so for me, it is about building the pipeline for this entire region. Having a large number of people who are coming through neurologists and being trained, even if they don't stay here at UB, but they go out and they serve that community, is critical for us. It's also about training physician extenders, as well as utilizing technology to get to remote places, to rural places where they can't afford a neurologist year round, but we can provide as much care as we can to those regions. So for me, I want to leverage the kinds of technologies and support systems that will allow us to extend our reach with a smaller group, because there really is a shortage of neurologists.
And then we got to recruit more physician scientists like
and
you
absolutely.
too.
And making those kinds of advances can dramatically make an improvement. One of the things I talk about is the blood pressure implant. Whenever somebody invents that thing that can actually read your blood pressure and
Put
lower
you out of business.
it can help a lot
Yeah.
with stroke, heart disease, kidney disease. These kinds, that's why research has been so important to make advancement beyond the patients that we see every day.
Yeah, you mentioned something I forgot. Yes, you're an expert in telemedicine and telestroke as well. So we're so glad that you're here and joined us at the Jacobs School, and thank you both. In closing, I just want to really thank our guests again, and I want to remind our listeners that here, at the Jacobs School, we're about transforming the health of Western New York. Today, we talked about the importance of neurology, both from stroke care as well as migraine, and we're really trying to bring bold new ideas and focus on excellence, compassionate care, and always with a commitment to our community. So for our listeners, thank you for joining us, and we want you to subscribe, and then we want you to share the UB Medicine podcast, and stay tuned for our next episode. And until then, take care, be well.